It is Wednesday, March 19th, and also welcome to our colleagues in the Senate. Senate Health and Welfare is joining us today on this topic. And this is sort of a new topic to us. And the reason I thought it would be interesting is, if you recall, way back at the beginning of the session, we did a walkthrough of a telehealth bill, and the committee sort of got really excited about AI. And I thought that today would be a great day that we could hear about it. So we have two witnesses with us, and I'm going to introduce Tanya Malik or Malik.
It's Malik.
Malik. Oh, I'm sorry. Excuse me. Forgot to mute my phone. Welcome and thank you.
Thank you.
You can go ahead and you can take it away anytime you wish.
Okay. All right. And then we also invited Michelle Hager. She'll do the second. She'll follow up with me. But so thank you for having me. My name's Tanya Malik. I'm a lawyer and an entrepreneur, and started telehealth businesses in 1999, way before it was cool, and have then just evolved into doing other things. But I also, so I did online primary care and telemental health. So it's a range of digital health companies that I started. And today I'm just going very broad on artificial intelligence and healthcare. And I have some slides and some flat examples, because I don't have a live demo here, but this, I understand, is just the beginning of a conversation. And so there's more we can bring to you and more we can show as you get more interested or have questions. So let me share my screen then. Oh, I need to send a request for that. I did. Okay. Okay, great. Okay. So I do want to say that I'm coming from the perspective of that I am embracing and think the industry should embrace artificial intelligence in healthcare while balancing privacy and safety concerns and maintaining some control. I was in a previous life, I was also a regulator. I regulated and prosecuted insurance fraud and worked for the Office of Commissioner of Insurance. So I do understand regulation a little bit, and I'm not putting myself in your spot at all, because you're way more an expert on this, but just being able to have a little bit of that lens as we talk. Okay, so today what we're going to talk about, we're just going to overview it some. I'm going to talk about the advantages of AI, and I didn't call it the disadvantages of AI. I called it the concerns about AI. The role of the regulator. Again, I'm not assuming I know your role, but it is something that people talk about all the time in this, as we're talking about healthcare. What are the regulators going to do? Are they going to stop us? What are they going to have legislation that's nimble? What's going to happen? Then I want to talk about digital twin technology, because I just find it really fascinating and where we can go in another way of having the advantages of AI. And then, will AI replace physicians? Oh, and I want to give credit to a lot. I'm a fellow in the College of Fellows at the American Telemedicine Association, and I relied heavily on some of the information I got from them and from the Medical Futurist. It's an excellent, it's a course and a doctor, Dr. Bertlin Meso, who is always looking forward about what's happening in healthcare. Kind of fun if you sign up for his emails. So I just want to start by saying that we already have a lot of AI in our life, and it's all around. And there's probably funny stories from where you've been talking about something weird at a dinner party, and then these ads show up on your phone. Even that's a little weird. But those Netflix recommendations that come up, we think this movie would be great for you. Well, they're just putting AI together and thinking of your profile and what will happen and serving it up for you. And if you pick it, then that gives them more and more data to serve up better things for you that you like. Your email, sorting your email by priority, that actually kind of annoys me. I try and turn it off because I want to decide what my priority is, but that's AI. Any Amazon picks for you when you are shopping, and it says this is what we offer you too. Any grammar assistance, you can ask any. My kid's 15 and she uses Grammarly anyway. It's helping them, or it's helping them in school. Google Maps, Alexa, and then fraud detection on credit cards, which we're probably all very happy that there's there, as somebody ends up, in my case, in Walmart with $600. So, oh my gosh, I have my Alexa on and now it's talking to me. So, um, she's telling me all the specials. I need to turn her off. Gosh. So, just a little bit of just very few definitions. So, algorithm is really a step-by-step instructions. I follow the instructions when I get a new Wayfair piece of furniture, and that's basically, it's just step-by-step instructions on what to do. Machine learning is more advanced, and that's what I'm sure you have heard of that before, but it's when we start giving the machine a set of data and it starts to learn better than we can because of the massive amounts of data that we're giving it. And it starts to demonstrate learning. So if you gave the machine, and I hope you've all tried this on ChatGPT or Claude.ai. I did it the other day because I was in a mess. Like, what is a quick side dish for a dinner where I don't know anybody? And it came up with everything, and it can give you the recipe. You can give it the recipe to start. That's how it started. It had a data set of recipes. But then it can improve upon that recipe. And that's machine learning, that it's just getting smarter and smarter as more data comes in. Maybe I went back to chat and said, I really didn't like that dill with that cucumber. Well, here's other alternatives, things like that. But the better the data, the better the answers. So garbage in, garbage out. Good data, good answers. And in healthcare, the people who have a lot of the data are the governments, right? And the payers. They know what's going on in their patient population. So basically, AI is pattern recognition, like cancer looks like this. So when you're looking at this pathology report or image, this is what cancer looks like. You tell us if you see it, those things. So here are the 5 different types of decision making in healthcare, and where obviously everybody knows what number 1 is: human only. You walk in, you talk to your doctor, she says, why don't we do this? You say, okay, and then that's it. That's part of your patient journey. What's happening much more now is shadow AI, which is listening in on the conversation between the patient and the doctor, and then documenting it for the provider, which in the mental health world, in the community mental health centers, it is changing providers' lives for the better. Instead of going home and documenting it, the documentation is done. And so it's a retention and recruitment tool for those community mental health centers who are doing ambient listening and shadowing and being in the conversation and then document it. And I'll show you a flat example of that in a second. Then there is suggesting, where it's decision support. They may be listening, or they may be looking at medical records or doing other things and suggesting this could be the diagnosis, this could be the way you handle it, but there is a human interaction in there. Then partial, they may see a mammography scan and say this looks like a problem and flag it, but then the doctor comes back and reviews it. And then full automation. And there is some of that going on today in healthcare. And Michelle's going to talk about that a little bit more, where you'll see examples like in retinopathy for diabetics and other things where there's some full automation. So AI in healthcare is already here. it's totally changed the physician-patient dynamic when I just got an Aura ring. Now it tells me how much I sleep and if I had a good night's sleep, which I resisted for a long time because I felt like I could do that all by myself. But there's genetic testing now, Ancestry.com, 23andMe, there's RPM, there's RTM, there's such a massive amount of data that's going on, and it's already here. It's using the benefit, it's now harnessing all that data, and how can you use it to do some precision medicine and get better outcomes. When you talk about outcomes, it's already providing some good, solid outcomes, certainly on image analysis and predictive readmission rates in hospitals. They can tell who might come back. And as you know, hospitals get dinged for that. And so it's a way to be better for the patient and better for the hospital. It creates efficiency, like I just talked about on documentation and other aspects that we'll talk about. And then there's a problem. I did a little research in Vermont, but it's well known that we have a provider shortage, certainly in mental health. And this is allowing, because it's creating efficiencies, it's allowing providers to practice at the top of their license. And so more complex conditions where you need human interaction and patients there and more empathy, it's allowing that to happen because these more menial, rote, data-driven tasks are being done by AI. And when I say more menial, like appointments and rescheduling appointments and those things, it's creating more efficiency in that aspect. So, as I said, I believe that AI is a win for society, and regulations need to be nimble without creating barriers for innovation while balancing safety. So that's easy, right? All before 9:15 in the morning. Sounds like really all before you can finish your coffee. Seems like an easy thing to do, right? So at the ATA, we have come up with this patient journey, and I just want to touch on this because this is us. This is what, as a patient, we go through. And at the top is the pre-care phase where you're trying to stay well and prevention. And there are all sorts of AI being applied there, to your Fitbit, to your Apple Watch, to the Aura ring that I just talked about, all of those things that just keep you in line. And we probably all have a story of the Apple Watch discovered a heart condition to someone that they love that happen. And they've been able to identify it and then take action. So same with symptom recognition, with all of the data that people are willingly putting on and checking and learning. And then you become care seeking. And even in the care seeking, you can apply AI from hiring the right physicians and putting them in the provider directory, and then matching up what the patient wants with what they're saying they want in a provider and serving up choices. And then the access phase and the intake and registration, that is clearly a great place for AI, where, especially in mental health, where the intake can be very long, you can have a chat bot talking to them. So there is some empathy and feeling like you're talking to somebody as intake and registration is happening. The same on initial assessment and triage. There with RPM, that's what's happening. They're being triaged all the time that the data is being collected. The active care phase and the diagnosis, treatment planning, and treatment delivery. It's just like we talked about in the phases of where AI is. It can help on the diagnosis, can help on a treatment plan, and there is treatment delivery when you think about medication. I don't want to go way to the Terminator, but there are robots who are taking the meds and putting them in packs and doing those kind of things. And then on the recovery phase, on monitoring and follow-up, RPM, RTM, we've talked about that. And even recovery and rehabilitation. There's apps incorporated with AI that will help you on your physical therapy and all of those things at home as you transition into being discharged, and post-care management, maintenance profession, and prevention, and it all circles back again. But the big circle and a big umbrella is the privacy and data security. So I just want to take us to imagine a doctor's visit where AI. One has hired the physician with AI, knowing who's more likely to excel. That is happening today. And it's happening in community mental health centers and other academic medical centers to be able to say who will fit better with this patient population, who will fit better in this culture, who will fit better in this environment where we work at nights or whatever is happening. AI is helping on the hiring and the culling of the massive amount of resumes. Oh, you've probably seen that in LinkedIn. Well, you guys, I'm sure nobody's looking for a job. I'm just assuming that if you ever went to LinkedIn and looked in it, it says, let AI help you on your job resume and those kind of things. So that is here today. The this I find really, really amazing, the collecting all of the medical records for a patient. So I worked with some veterans before, and the biggest hurdle was them getting their medical records. So now, and when you think about life, you may not even know what doctor you saw. Like, oh, yeah, I went to Boylan Medical Practice, but what doctor was that? So now, with patient consent and AI, they can go through and call out all of your medical records. Right now, they're at about 90-ish% accuracy in getting not accuracy, I guess I should say completion in getting all of them. They can't get images today, but then they can summarize it all. So as a VA, as a veteran, you have all that's all done for you, and the summaries there for the provider so they know what they're talking about with the patient. So, and then you can analyze the data, all the data the patient provides. Just put the veteran example to the side for a second. Just someone who has Fitbit and Ancestry and all of those things we've just talked about can analyze it all. Then you have AI listening to the conversation so that the doctor and the patient they're talking. They've already analyzed it. The doctor knows what's going on, and this visit can be efficient and effective and empathetic and with a treatment plan that everybody agrees to. And the power dynamic has changed because the patients say, no, my Fitbit is saying, my heart rate was 120 when I was sleeping, or whatever the example needs to be. They can say, I think they can be a real advocate for themselves, but it's all layered with AI, and a lot of that is happening today. So here are some of the benefits, and then we're going to get to some of the concerns. But speed and analysis, some examples. It took 15 seconds to diagnose a heart problem in some studies, as opposed to 30 and 45 minutes. Quantity in the analysis. I just mentioned the VA records and also cancer patients. It's be able to take all of that quantity of that medical data and be able to analyze it quickly. The complexity and the tasks. So there is one company who found that the COVID pandemic was happening 5 days before the World Health Organization, and 5 days of the COVID pandemic was a lot. This finding unusual associations, I think maybe Michelle's going to talk about it a little bit, but there have been PET scans that show Alzheimer's indications. There have been retinal scans showing cardiovascular issues. So that's a huge benefit because the data is so big and the human brain is great but limited to being able to find, and medicine's so siloed. So our cardiologist knows what it looks like for the heart, and they're probably really great at it, but would they have thought to do a retinal scan? So we've talked about provider shortages and how this can help, how it empowers patients. We've talked about that. And we've also talked about letting physicians operate at the top of their license. We're going to talk a little bit more about precision medicine when I talk about digital twins, so I'll hold that. But this one I found, this wasn't my idea. This came from the medical futurist, but when he said it, I was like, wow. When AI gets it wrong, they should get it wrong once or rarely because they're learning. So if a doctor gets it wrong once, they will learn again and they can apply it to a different situation. But how does that knowledge get disseminated? So here, you have machine learning where if they got it wrong, the chance of errors greatly reduces. I just want to say wow on that one. That's like, So here are some of the dangers, but they're worth the risk if we can stay in control. So AI bias, that's says basis. So there's a typo.
I'm going to interrupt you because we have a question. Leslie?
How does AI know? Thank you for your information. How does AI know it got it wrong?
That's a really good question. And I think it would have human intervention to know that it got it wrong. Like I use Claude AI and Claude has gotten it wrong twice. And women come to the table with, we maybe not know everything anyway. And so I checked it like 3 times. And it's named Claude, which is a guy, which is, anyway, I'm getting way too you're getting into my therapy now, but and I'm like, Claude, I think you've got this wrong. And I told him where I thought he was right. And he goes, thank you. He was very polite. Thank you for telling me I got it wrong. I'll put that in my database now, and so I'm one thing I remember, I don't remember the second thing that he got wrong, but it would have to be humans teaching them and
Yeah,
telling.
could you say more about that? Because the implication I took from what you said initially is that AI learns.
It
But
does.
I mean, I understand that it learns, but in your last thing, it's one-time mistake. And what I'm hearing you say now is that requires human recognition of that mistake in order to repair it. Is that what I'm hearing you say?
I don't think it requires just human intervention. In my example, it did. I think the more data that comes in, so if it spots something on an image that it thinks is cancer and it's not, we need to feed it more data to show what cancer is. So it is a continual evolving. And the way that it works, it's in a silo, it's analoged as far as like you might not be able to ask the same, what does a cat look like? Can you show me images of cats? So the same AI that's doing cancer scans, they might not be able to tell you what a cat is. So it is important that the right data is getting fed, but it is a continual loop of data. I don't know that I'm answering that well for you. And some part of it is, I don't know all the answer on how that happens.
Yeah, thank you.
Yeah. But
Thank
as
you.
we start this conversation, those questions, we can answer all those as we go.
Monia, would you want me to jump in there for a sec?
Sure, if you've got a better answer, absolutely.
Sorry, just getting my camera going. So as Tanya said, the data sets learn based on larger and larger data sets. So what happens, the machine learning and all AI requires more and more data sets to be able, so it's not a stagnant scenario. You will see that institutions, healthcare institutions are across the spectrum, whether they're providers or payers, are engaged in relationships with artificial intelligence companies to provide data to those companies so that they can continue to improve. If the AI companies do not get that data or those large data sets from those institutions, they will not improve. So a great example that Tanya just said was about the cat. There's a famous example of Google Gemini. People right now often, and it's catching up pretty quickly right now, respond and know information more quickly than AI. So, or more correctly, let me say, than AI. So for example, in the example with Google Gemini, they show a picture of a duck being drawn, and the person knows that it's a duck well before the artificial intelligence software knows that it's a duck, and it believes that it's an actual duck, but the person knows that it's actually a rubber duck. And eventually, over the steps, the AI does recognize that it is a rubber duck and that it doesn't belong in a pond, it belongs in a bathtub. But it needs more and more data in order to improve. And so that's how it knows that it's making mistakes over time. I hope that helps.
Thank you.
And so that's why Michelle's going to talk a little bit more about full in those 5 steps we talked about. I think we're at a comfortable place at partial where the AI says something, but there's human oversight on it. So, but it wouldn't make that same mistake twice with the human oversight. So there's my typo. It's AI bias. And what that means,
I saw
we're all
that.
human. I'm not AI, but I am not a deep fake, which actually is one of the things that is a risk. But the bias being like in dermatology right now, the data set that is being fed to the AI are more applications for skin that's lighter. So darker skin, different toned skin isn't getting the lesions or any of the abnormalities are not getting picked up on that skin. That's an example of the bias. Things are moving so fast that they're not getting peer reviewed. Like things aren't getting, they're not doing the long studies. I will say I haven't talked about it here, but AI in clinical trials is really speeding up the clinical trials, and which is a good thing. More drugs will come to market sooner, but I would just things aren't getting as vetted as normally they would have it because it's moving so fast. And then the regulations don't change quickly enough, and you could stymie innovation. There we are. I don't need, you guys got that. Privacy, but you already have state privacy laws, you already have HIPAA, you already have these things in place. So, of course, it's a concern, but there are already structures out there. Cybersecurity, but we're even at the age of, we think cybersecurity and big hacking and change healthcare issues, but we still need to keep in mind that people are clicking the links in those fake emails, and that's a problem. So the phishing is still an issue. Deep fakes, I did learn how to spot a deep fake. So deep fake, of course, is you think you're talking to someone that you're not. It's different than I just want to bring it up, it's different than an avatar. But the way you spot a deep fake is you ask it to turn your head to the side, and if they can't turn their head, they're fake. So look, I got it. Got it. So, and who has the legal responsibility? I think this is what people talk about. As a lawyer, I don't feel like that's a big concern. I think we don't have full automation on all of it yet, and there's still a doctor, and people aren't going to sue an AI. I don't know how you would sue an AI avatar and those kind of things. So, but it's worth a discussion as you go through it. So what's happening out there? Patients are independently using the technologies that may not be vetted anyway. So there's patients it's a group of patients who are diabetic, who are tired of waiting for certain things to come to the market, and they get together, they meet, and they're creating things and using them. Patients' rights on consent, I think Michelle's going to touch on that a little bit more, especially with Better Health. Like they do need to know that they're talking to a chatbot or an avatar or whatever they are. And generally you'll see it. I'm sure everybody's talked with chatbot at this time, and they'll say, I'm the virtual assistant. So that legislation has to be balanced and nimble. Bringing companies to the table and discussing where the technology is going, because it's moving so fast. There are entrepreneurs out there thinking of a lot of different things that, and it could be interesting to bring them to the table and see what they're thinking about and how you could help them. And then existing laws may be sufficient, and federal laws can be a guide. Michelle's going to do a great job of showing you what's already out there and to highlight that for you. Oh, I added this one. There is a whole state tracker, but this was just signed this week, so I thought it was kind of cool to put it in. But it's basically their AI focused consumer protection bill, and they set up a whole another really Office of Artificial Intelligence Policy. They created a whole nother state arm to talk about it. So there are my point is there are other examples and places to go. I'm going to see if you can see this well. This is an example of an AI behavioral healthcare company called Videra that listens in. And so this is the output of a therapy session. So the provider didn't have to write any of this on the data, on what they reported the difficulties, what the assessment is, and what the plan is. Now you can see over here, it says add to notes and regenerate. They can dictate more notes. They can do other things. It will go right into the EMR. If there's no EMR integration, then they can easily copy and put it in the EMR. But that's what happens just from them listening to the session. All that gets done for the provider.
Can I ask a question about privacy?
Mm-hmm.
So if AI essentially learns from past, say in the case of Gordon here,
Mm-hmm.
so the AI is writing Gordon's notes
Mm-hmm.
based upon previous writing of notes and learning what to write and how to interpret and how to document the information that it's hearing into a cohesive note with a subjective assessment plan. Isn't ultimately it getting that information from, say, another patient? And
No, I know.
where's the privacy in, or I mean, just HIPAA?
Right.
Mm-hmm. So in this particular Gordon, so the AI just listened to Gordon, right? And it's listening for certain keywords. And so it's just like, I don't know, like on this call, AI companion can summarize everything we're saying. So, and then do a to-do list. It's actually amazing. You should probably use it. I mean, I use it all the time. I don't, it sounds so patronizing. You should use it. But this is, it just listened and summarized it. It doesn't mean that it had to go out and bang a database or do anything to do that data part. The assessment part, it's picking up on the word sleep and that he struggles to get out of bed and those kind of things. It's picking up on those words to put the assessment into he's having significant sleep disturbances and irregular eating patterns. Those things are still within the confine of just this visit.
Yeah, I guess I'm not explaining myself. But isn't it learning how to document Gordon's visit? Isn't that informed by how it documented, say, Claude's visit before Gordon? Isn't it learning from all the visits that it's written and continually improving itself? And so isn't it storing that information on everyone?
Well, it's not storing Gordon's information. It is matching his information through the data set that they've learned about sleep or not. So there's still, but I do want to say, you asked about privacy in the first, and I believe that Gordon had to consent to this, right? So that he knew that there was ambient listening. But I do think this conversation, this therapy session is in a silo for privacy and security. What has worried community mental health centers is the recording being stored, but it's not being recorded. So it is continually learning, but in the aggregate about sleeping, not about Gordon sleeping, about here are other things that identify sleep disturbances.
Okay, thank you.
Michelle, you want to add to that?
Yeah, I was just gonna add, so that the way that the machine learning takes the data in is it takes it in aggregate and uses that to determine trends and uses that to determine the likely outcomes, likely so at this point it's not infallible. So it's not necessarily saying, oh, I had a patient that had sleep. And let's see the note and that was Michelle. And let's see the note that we did for Michelle. And let's copy Michelle's note and put that in. What it does is it looks at the information that it did for Michelle and the information it did for Tanya and the information it did for Lisa and Joe and whomever else, and aggregates that from a trend perspective and then determines that this is a successful summary of that visit or a successful description of that visit based on the information that it has previously. So a good example would be, again, back to that Gemini example, which was actually kind of dispelled a little bit a few years ago. But anyway, the point being that example, we know that the machine learning did not actually do a good job of learning what a duck was, right? But it took in that information. So the next time that it looks at a duck, it'll recognize, oh, that's not an actual duck. That's a rubber duck. So it's trending data versus individual records and copy and paste. Does that
So it
help?
does become personalized, but on an aggregate basis, if that makes sense.
It does, thank you.
Okay. All right, so I love this technology and know very little about it. So you might ask me a lot of questions, and Michelle can help me because it's just such a big, great, interesting concept. But it's digital twin technology, which actually has been around for a long time. It's been used for decades to predict machine failures. I always think of the big machinery that cost a lot of money. They're using predictive digital twin technology, which is a virtual replica of a real world counterpart. And it's constantly updated based on real-time data. So traffic patterns in a big city, those kind of things have digital twins. But now we're talking about it in healthcare and it's being used. And we have actually been talking about it for a couple years in healthcare, but it's really being implemented now. And it can be used for precision and pop health. So the question you just asked um, is really relevant as we go forward talking about digital twin technology. So what it can do, well, one, the documentation that we talked about, the digital twin can help in it can be in the healthcare workforce. This is just applying it in the healthcare workforce, which is where so there was a presentation at the ATA. This is where one company has started using it, and they have started on their own employee population. So at the workforce level, it was helping on the documentation. 30% of their nurses' time was being spent in documentation, and with the digital twin and something similar to what I just showed you, that took that off their plate. It also was just simply telling the human nurse which room they had to be in, like you're needed in this room or that room. But what's happening on the employee population level with the digital twin is so you have a virtual replica of you, and say you have cancer, it can go to this level. Let's see what chemotherapy can work better on you as opposed to doing it on you and seeing what happens. They can put different technologies in place and to see what happens. That the example they were giving is in the diabetic world. For a doctor, the doctor's tool mainly is prescriptions. So you have the visit, you come to your doctor for the 7 to 10 minutes, they write you a prescription and say, eat better, get better sleep, reduce your stress, work out. Okay, well, that's a lot to take in. So then you come back, in 60 or 90 days, things haven't maybe gone as well, and there's another prescription. So it's dissatisfying for the provider and the patient. But what's been happening with digital twin technology is they take a digital twin of the patient and be able to see exactly what is working to get the A1C down. And then in one particular case, nothing was really working and they were recommending insulin. And then the patient was getting labeled non-adherent. And through the digital twin technology, they found out that patient was afraid of needles. So that treatment plan is never going to work for that patient. That patient is always going to get labeled non-adherent. But because the technology was in such a precision form, they were able to find that out about that patient, be able to readjust and make better decisions, which is better on a population health basis for that employer. All of the information that's going to the employer is de-identified for privacy concerns, but it's a way that they can also, so I'll pause there for a second and move to where the technology can be nudging the patient to do certain things and then notify the care team that they've nudged the patient and this is the result. So everybody has the same communication. They can be more efficient and they can maximize their time. I know that was a lot. I know that was a lot. And I contacted a company yesterday to see if I could do a demo, and they're just not. There wasn't enough time right now, but maybe later, if you're interested in that, you can invite them in because I think it would just be amazing to see. And then I just have a couple more things, but we've all heard about the avatars and in mental health in particular, we think you'll be getting your mental health from an avatar. There's Weebot now. There's a couple of others that are out there. It's not very pervasive, but there are nurse avatars now, mental health therapists that are avatars, and peer-to-peer support. So you think you're talking to a peer, and it's an avatar. Again, the patient needs to know that, but that's definitely coming and something to think about. And then will AI replace physicians? I loved this quote by the medical futurist. AI will not replace medical professionals, but medical professionals that use AI will replace those that don't. So that was a lot on a Monday morning. I mean, it's not Monday shit. Excuse me.
Wednesday.
Wednesday. So I'll stop sharing here and see if there are any other questions or anything I can do. Michelle's got more information for you.
Let's start with Leslie and then Woody, you have a question?
Thank you. Thank you for your presentation. You mentioned Utah enacting an AI-focused consumer protection bill. Is that something you're recommending for Vermont?
Oh, I'm going to defer to you guys. I was just giving you an example of that, what someone else did. There's a state tracker out there that I'm going to try and get my hands on or maybe you guys already have it on all of the state bills people have done on AI. It's just a thought. I don't know. It's just one way they've handled it.
Well, I guess what I'm asking is, do you think consumers need protection?
I think you can do it in the construct that you have. That's what I would say. Yeah.
I'm not sure I know what that means. I'm sorry.
I just think there are enough data privacy laws out there, enough privacy, there HIPAA's out there. There's lots of protections on the state level, but I mean, I don't know them as well as you do on what you have in Vermont. Utah's been a leader in accepting telehealth and they've had different laws. They just took one off the books that was allowing direct to consumer, more direct to consumer telehealth. So I think there could be existing laws or AMA guidance and things that are already out there. And Michelle's going to dive in further into that.
Thank you.
We didn't ask her to get freshened up on Vermont law specifically, just so you know.
That's up to her to know or not know.
Woody, and also Chair Lyons, I didn't know if anyone in your committee had any questions. Feel free to jump in. what do
Yeah.
did you want to go ahead?
Sure. So my questions are, where is all the AI information stored? Is it, if you have a physician, is it stored in his offices? Can AI shut down? Is there backup, for this material?
Michelle, why don't you jump in here because your IT basis will be good.
Hi. So it can be in a variety of different places, but typically they are large data sets in the cloud. And yes, it could shut down and it's not stored. Depending on the organization, say for example, a health system, they may have requirements that data be stored on site or in, disaster recovery locations where they're, storing data today. But those would be EHR records per se, not the algorithm of the AI or machine learning technologies necessarily. They are generally cloud-based.
Thanks.
All right. It's like no more questions. So I think Michelle might have a presentation as well. If you wanted to. Oh, I'm sorry. Senator Lyons, did you raise your hand?
No, okay.
Oh, okay.
No, thank you. This is terrific. We appreciate it. There are no questions from here at the current time.
Okay. Thank you. Daisy, did you have a question?
I did. Tanya, thank you so much. That was really amazing and mind-blowing and exciting, frankly. I'm left with this question around how do we continue to strive toward health equity? All of this AI stuff, I just will be frank, it looks, sounds, smells expensive. And I just, we're a rural state, as you know, and we're struggling right now. And can you speak to how equity is woven into some of these technologies that you've introduced us to?
Well, I think this is all based on telehealth too. It makes it more efficient and it can reach rural areas. And so wherever your state of telehealth is, I feel is where your equity is going to be. If you have a robust rural network where people are already getting their health care through telehealth, then I think there's a real chance of equity off of it. Do you have to have an Oura Ring for this? No. Do you need to have broadband? Do you need it? Yeah. I mean, yes, you do. So in your very rural areas, I don't know what you've done to make sure telehealth is available or healthcare in general is available there. But I think that helps to be the great equalizer for it's just getting more access to care. So the good thing about this, like the RPM, RTM, those things can happen at home, but and that has nothing. There's Medicare reimbursement for that. There's all of that. All those regulations are about to change to maybe increase to increase reimbursement for RPM. But those are the things that make me think about on an equity basis. But Michelle, you look like you want to jump in.
No, yeah, so I agree. This is a great question because it is a challenge and I'll touch on it actually in my presentation, but every organization is struggling with how do you ensure fairness through this because it is expensive. It is technology that we all know right now, last mile connectivity is difficult, particularly in rural organizations and rural areas. And what we're seeing is each individual state is putting something together around a fairness or equity and those professional boards that are regulating providers related to their use of AI and their recommendation and guidance around their use of AI to ensure that there's fairness in all the services that they're providing, excuse me. But we know that this is a problem because when AI first started, there was race bias in the technology. You may have already seen that as part of, your own research on this, but we know that that is a problem and it is working its way out. Is it completely out? No. And so it's evolving technology. We're at the bleeding edge of this, and unfortunately, it evolves so fast that it's very difficult to keep up, and for people like you to be able to understand where should we be, because you're always, I think I used the example the other day, you're always going to be the caboose in this train, and that engine's going to be driving, and you're going to go, how did, we didn't even know where this train was going. So, and right now, we don't always know where it's going.
Thank you. Great, thank you.
I think I can you see my presentation?
Yes, we can, thank you.
Okay, I'm just gonna full screen it there. Is that better?
Yes.
Okay. Thank you. So I am the managing partner of Blue Sierra. So we've been in business for 15 years. I think you've got a little bit about my bio, but I'm kind of a IT policy wonk and participate in the public policy forums for both the American Telemedicine Association as well as CTEL, which is the Center for Telehealth Policy, and ELAW. And the reason that telehealth has been kind of at the forefront of this, or some of the AI technologies in healthcare, is because not only do investors in healthcare are driving that and trying to find more and more efficiencies through machine learning and investment, and we're also seeing this helping with virtual care in general. In some of the examples that Tanya already shared in ambient listening, for example, where this is already listening in on patient visits. So from an agenda perspective, for me, I want to talk a little bit about what organizations are saying about AI. So this might help inform you and how you might be able to anchor some of the work that you're doing in determining what legislation should or should not be put into place. So we'll talk about the AMA definitions and guidance of AI, or what revenue cycle usage in AI, which I was specifically asked to speak on. Some of the largest technology companies that are utilizing AI today and what they're utilizing it for, specifically in healthcare. Some case studies of some companies, some ONC guidance. So ONC is the Office of National Coordinator, who governs technologies or advises on technology and regulation across the country. Some payable CPT codes for AI work that is today payable for you to be aware of as well in your research and journey. Some legal considerations, the current bills that are floating around in different states and what other people are doing, and some trends and some ethical considerations as you navigate this world. So the AMA, for example, has defined AI as not artificial intelligence, but augmented intelligence. And it did that intentionally because it does not replace the human decision-making in medicine. So those decisions that the AI is making is not, in fact, a medical decision, but only assistive to the physician. So for example, the question of whether or not AI would replace a physician, the AMA would emphatically say no. That is not the case, because it is not replacing what the physician is doing. It is only augmenting what they are doing in terms of their service to their patients. Interestingly enough, we've seen that the AI tools have been tested for passing medical boards, and initially they all failed the medical boards. And recently they all passed, and passed better than any other medical student that had taken the boards that year. So they would have all been admitted into medical school. So we see the learning happening. We see the aggregation of data and the adaptation of the technology as we test it, as we continue to move through the evolution of this technology. So advice from and guidance from the AMA defines that AI systems must be transparent, explainable, and evidence-based. And that explainable piece is probably one of the most important definitions that you want to think about, because if I can't explain where that information came from, to your question earlier around how does it know that this is the right summary note for this patient, it needs to, the physician needs to know that it is explainable. I can actually utilize this to provide my data. I see a hand up, so I'll pause.
Thank you. This is Senator Lyons, and thank you. This is both of you. This has been really very helpful to us. I do have a question regarding the folks who are taking the boards and the tests and their ability. They are doing better as a result of having AI integrated into medical education. Is there tracking on the clinical experience with patients so that I understand from my own experience there are, data acquisition and utilizing computer assisted technology is critically important. However, it's also critical for healthcare professionals to have social integration and working with people and patients. So do you have an understanding of how this is integrated with those experiences? Are we tracking, is this a replacement or is it complementary to?
Right, good question. So one, I want to make sure that I'm clear that the AI technologies were the ones that took the medical boards, not the students. So the AI technology took those medical boards, initially failed, and then all passed, and they would have done better than all of the students that took the medical boards during that same cycle. It is not replacement from the AMA's definition. It is assistive, it is augmented intelligence, and you'd see a couple bullets further down that the AMA is actually recommending that AI be integrated into medical education to ensure its proper use by healthcare professionals. I'm also on the board for the advisory board for the University of South Carolina, Medical University of South Carolina as well, and their curriculum development. And each organization, each healthcare or each academic institution that I'm part of, they are all integrating AI into their curriculums today.
Okay.
That helps.
Yeah, that helps. Thank you.
You're welcome. In each of the areas where I am noting information from another organization, I'm always going to include that link so you can jump into it later if you have the slides and you can look at those links at a little later point. Some of the ethical considerations that the AMA is defining is prioritizing patient safety and privacy. We already know that today our youth are less concerned about privacy, and they are putting information out into algorithms that are utilizing artificial intelligence. So we'll see how that evolves over time. But today, patient privacy and their safety is utmost concern for the AMA, for example. And developers and policymakers should collaborate with the physicians in order to shape those AI regulations. I'll talk about that in my last slide as well, where I recommend you potentially go forward and put together some of these collaborations with the AI technology developers as well as clinicians in your state.
So I think we have a question from.
I'm wrong.
Yes. I want to talk about information and how it's gathered. Does an AI system, is it capable of examining a patient's record and seeing that, be able to pick out mistakes in that record?
Great
And
question.
let me tell you why I'm asking that question. My record got mixed up with a woman. It took me quite a while to get it straightened out. So I'm wondering if AI could do that quickly and eliminate all that stuff I had to go through.
Yes, short answer, yes. I'll use a couple of examples as well. So Clear is using, if you know Global Clear, when you go through an airport, right? You're looking, they're checking your identification. Clear has a healthcare arm where they are utilizing Clear for identification purposes at the point of registration, so that we know exactly who it is that we're talking to and who we're registering and who is getting this care. So that has a couple of different implications. Obviously, we're ensuring that we are caring for the right person and those records are actually correct. And they are matching, to your point where you got mixed up. And also it prevents insurance fraud, where we know that some people have shared insurance cards, for example, put in fake names just to be able to get insurance and to get coverage to be able to go to the doctor. So Clear is knee deep in healthcare right now for that exact purpose. I would also note, when we talked earlier about data sets and how AI and machine learning pull in that data, a good example, again, would be around sepsis patients. So it's not, the technology is looking at all of the data that it has received. So if it only has a small sliver of information, then it isn't necessarily going to be very good at analyzing a sepsis intervention, for example. But we know now that they have had large data sets in identifying potential trends in patients being septic and have accurately predicted that, which of course is reducing mortality in healthcare settings as well.
Thank you.
Thank you.
You're welcome. The AMA has also defined principles of artificial intelligence, or augmented intelligence, excuse me, when we talk about the AMA, and they want to have responsible oversight. They know that there are key benefits for AI, and Tanya talked a lot about that already, which is enhanced decision-making, improving that diagnostic accuracy, and also looking at optimizing those treatment plans for better outcomes for patients, which is a patient satisfier. It also reduces the administrative burden, which is huge for clinicians in already a shrinking workforce with physicians and all clinician types across the spectrum. So we know that documentation, we know that the prior authorization process, we know that claims management, all of this is time consuming for the clinician staff, and this allows it to be streamlined and to reduce that administrative burden. It also assists in improving the clinician's well-being. This allows them to reduce those repetitive tasks that Tanya talked about, reducing their burnout, and can make a more sustainable work environment for those clinicians. If you follow a physician around, you will know that they will do their visits with the patients, and then they will spend an hour or an hour and a half at the end of the day going back and documenting, and maybe even longer than that. I know a great physician, a friend of mine spends their Friday mornings going back and documenting all of their dermatology work that they are doing. So it's a great administrative burden, which is a dissatisfier for people in clinical work. And we already know that clinicians are leaving this industry in part because of moral moral pain, for example, the way that they see that I'm not terming that correctly, there's an actual term and I can't get it into my brain just yet, but we know that moral injury, that they know that they are seeing their profession changing. And obviously the administrative burden is also a factor for them. Enhancing those patient safety areas where we know that AI is able to detect errors, to your point earlier and question earlier, when those AI systems are properly validated. Again, this is where the explainable word is important. Flag potential risks and utilize that for clinical decision support. And obviously promoting health parity and fairness in the use of machine learning and AI tools. It can be a good balancer of in addressing disparities in healthcare and providing the tools with the attention to reduce bias and increase inclusivity.
Oh, one more question.
I want to get back to the information now on that, and that enhancing the patient safety. It says AI systems when properly validated. What's that mean?
Right, from the AMA's perspective, they want to have clinicians integrated into the development of those AIs. They want them to be part of the testing of those AI tools to validate them. So when an organization, for example, a healthcare system is utilizing AI, they go through a tremendous amount of testing in order to ensure that that artificial intelligence or augmented intelligence is in fact returning the right information. So anytime you do any kind of IT implementation in an organization, there's a tremendous amount of testing and what we would call a user testing process or a user testing interface. And those folks would need to look at that information, determine if it is actually providing the right information to them, and validating that information before it is live and utilized into that institution. So that validation phase has to be done from the AMA's perspective and guidance, has to be properly validated, utilizing clinicians to ensure that that data is correct.
Thank you.
So in revenue cycles specifically, the usage of AI is utilizing it's going pretty quickly in automating claims processing. Claims processing for clinics, for independent physicians, even for health systems, it's a tremendous amount of financial burden for those institutions to process claims. There's generally third parties that are in the middle of them in order to make sure and what they call clean the claims. Those claims will go from a provider health system, for example, and it will go to a third party to clean those claims, and then it will go to the insurance company. So there's an entire middleman process. What we're seeing is automated claims processing that goes direct to the insurance company because those claims have already been identified and have been cleaned prior to going to the insurance company. We know that that makes more accurate claim submissions, and they also go faster as well. And in a health system, they're always trying to drive down AR. So that is the time scale from the moment that the account is fully complete. And once that patient's visit is fully completed in the EHR, from that point until payment is received, they're trying to reduce those days on a daily basis. And this technology reduces those days. Fraud detection and risk analysis. We're utilizing that, and the algorithms are analyzing those claims to determine if there's fraud, waste, and abuse, and reducing those financial losses. So you can see that being done on the insurance company side, as well as the health system side, looking at, do we have someone who is potentially coming in with an insurance card, and we saw a trend. Michelle Hager came in for opioid addiction, and then she also came in for a stroke, and she also came in for a surgery. So all of those things happened in a time scale that maybe a person wouldn't be able to put those data points together. But the AI is like, hey, hold on a minute. We're not sure that this is the same person because it's unlikely that they would have all of these services within this short period of time. And then on the other end of that, the insurance company is looking at that to determine whether or not there is, as well as the federal government, looking at this from a fraud, waste, and abuse perspective to determine if there are patterns. Do we have overprescribing? Do we have a particular physician that is coordinating with, say, a DME company, and now we have, fraud happening? Those types of data points and patterns we may not be able to recognize because of their distance from each other, but the AI would be able to collaborate and pull those together. Utilizing predictive analytics for denials. So this is a great way for a health system or for a clinic to be able to look at their claims and historical information and determine whether or not they should make corrective actions on their documentation. Should they make corrective actions inside of their EHR to improve documentation, to improve data points, and then improve their overall rates of payment? Real-time eligibility. This is eligibility of a patient's services. This is where CLEAR would also help in the identification of the patient. We know that they would identify the patient, and then any of these eligibility checks happen at the moment of registration. You may not even know that this is happening today. The systems go out and automatically ping to an eligibility and coverage database before those services are rendered, and it minimizes those payment delays. They know right away if that patient has the insurance coverage or not. And you probably have experienced that in your own lives and your own family's lives, where perhaps they've said, oh, your insurance company said you're going to have a copay for this surgery, or you're going to have a copay for this procedure. That is because of real-time eligibility. They're utilizing AI in these patient eligibility coverages and checks now as well. And then revenue cycle optimization. It's also utilizing that by streamlining coding and billing and collections and reducing those administrative burdens. So any of the coding, billing, any of the this is a very frictionful environment where if you've been in a health system or a clinic where they are billing their own claims, this takes time, it's tedious, and this allows for an organization to streamline those administrative burdens around billing, coding, and collections of payments. Natural language processing. For documentation. This is similar to what Tanya was talking about earlier, but is more on the idea of a clinician the AI is listening to critical information from those medical records to ensure that the claim and coding submission is clean. So we know that they're listening to the clinical summary. The natural language processing tools are listening and creating documentation. As you saw that in that example that Tanya showed, it went from a plan to the summary to the actual documentation. So those were slightly changed based on the clinician intervention on that final documentation, but this is allowing them to ensure that they have the correct information, those right terminologies in order to make sure that they do have a proper claim submission and coding.
Good. Can I ask well, I have several questions on this slide, but can I ask specifically regarding that? So the documentation tool, using AI as documentation, and then using AI to code. So
You're concerned
I'm
about
sorry.
coding and
are they coding? Is it possible for AI to code the claim based upon the documentation? And is it also possible for the documentation to document based upon the coding, vice versa.
Right, so the concern about upcoding, that it would not be appropriate for the visit, that they would say, well, let's maximize our revenue, and upcode. It's possible, and I think this is where you have to look at the ethical use of the natural language processing, the AI tools, and determining what the regulation or what the guardrails and recommendations and guidance would be around the use of those tools. Today, I know that organizations that I have interacted with that are utilizing AI, they are not currently utilizing, again, it's assistive to the staff. So it is not utilizing it to beget the other one. Documentation begets coding and coding begets documentation. Those things happen in a sequence. And so they're utilizing the documentation to assist the physician in reducing their administrative burden. And when that moves to the medical records coding element, the natural language processing and the AI is utilizing that to determine, is saying immediately defining that, you know what, this account or this visit doesn't have, which happens all the time with human intervention, this visit does not have proper documentation today. Physician needs to include justification for this level of complexity that they are suggesting. So we need to know that rather than having that be human intervention, it is now AI immediately kicking that out and saying, this is not, we need to clean this before we can even send this to the insurance company and potentially get a denial. Where in the past it might have gone through and would have received a denial, and again, increase the AR days.
Is that what you're referring to as including the scrubbing process of the claim? So it's making the comparison to see if it's coded appropriately to, I mean, I always think of like cleaning a claim as ensuring that it has all the proper codes, modifiers, what have you.
Yeah.
But is AI scrubbing claims to identify where the documentation does not match the
Yes.
claim, and then speeding up the process of being able to correct that before the claim is submitted?
Exactly, and it's also utilizing it to catch contractual requirements. So obviously with each payer, there are contractual agreements, and the AI has those rules built into it, and it's able to determine that this particular claim is not going to pass based on the rules that were established as part of the contract. And so we need to include a different modifier on a simple example, but it might also be that this particular insurance company doesn't allow a needle stick, or it doesn't allow it allows for the, and I'm not a clinician, so I apologize, but it doesn't allow for, the actual administration of the drug, but it allows for the drug to be paid for example. I know that's kind of a weird example, but it does happen because it happened to me, which is weird. Why I could get the drug but not have it administered. I guess I have to do that myself. But anyway, the point being that that would be based on contractual requirements as well, and it would catch those details in the natural language, in the AI tools.
Thank you. Oh, wait, I'm sorry. One more question from.
I'm curious, with all the benefits that AI provides, whether it be for treatment or, processing claims, or what's the cost of all of this for, maybe a small clinic or, or a hospital?
Yeah. So, I have a slide on some of the companies that are utilizing it. Small clinics are unlikely to be able to afford an individual AI tool. And what is more likely is those AI tools are being embedded, and that is happening. They are being embedded into the EHRs that they are purchasing now. So, for example, eClinicalWorks, which is a very popular EHR that clinics use in individual offices that are not necessarily affiliated with a large health system. They would use a system like eClinicalWorks. Those additional tools are expensive. They are tiered based. So if you are a critical access hospital and utilizing eClinicalWorks, then your costs are lower than a multi-clinic organization across multiple states, for example. And that's embedded inside of eClinicalWorks. It's also embedded into Epic. And some of the other tools like Oracle. And I know Tanya's on the screen, so I'll let her jump in as well.
Just to give you an example, for a small community mental health center, the technology I showed you, which by the way, they are getting tired of point solutions. They do want one vendor who will bring everything. It can either be embedded in the EHR, like Michelle just said, or it's about $75,000 for them to buy that. And when they look at the ROI on that, the retention and the recruitment for their workforce makes $75,000 palatable for them because it is increasing their provider satisfaction and retention. But just one data point for you to see that.
Yep, thank you. Does that help? Did that answer?
Yes. Thank you.
You're welcome. I think when we look at appeals and submissions, same thing. This is helping healthcare providers appeal those denied claims effectively. It's obviously identifying them, pulling out tasks for billing and claims processing folks to be able to effectively return those claims back to the insurance company and be successful in their appeals of initial denials. There's also personalized payment plans, but I think that's maybe less interesting but that's for a patient. If there is a financial data that has to be tailored to that individual patient, the AI could be pulling in a variety of different data sources, including credit data, their outstanding bills, a variety of different data sources in order to determine what is an effective payment plan for that patient for any outstanding bills that they might have, or if they are a self-pay patient. Go slide, thank you. So some of the largest tech companies that are utilizing AI today, IBM Watson, that you heard about probably some time ago, they've been constantly working at IBM Watson Health to improve healthcare and is now part of Merative. They've been using AI-driven diagnostics. So the question is whether or not the patient should be aware of any diagnostics that were developed or diagnosis and plan that has been developed. Should the patient be aware that AI was used in the diagnosis and treatment plan development for them? These are ethical questions that need to be answered. Google Health and DeepMind, which have developed models for disease detection and prediction. So the example that Tanya gave, where they are looking at the skin to determine if you have skin cancer, it's extremely effective. It's actually more effective than a human on identifying anything on the skin, any cancer diagnosis and detection of disease on the skin. So it's very, very effective. It's also very effective in radiology as well. We are seeing actually the medical schools changing their medical programs as a result, and helping to change their curriculums for radiologists in particular. Is there a question?
No, I don't think so.
Okay, I thought I heard something. I apologize.
Oh, I think it was a cough, but
not allowed to do that. Microsoft Health integrates the AI into clinical workflows. I have an example of the ambient listening devices that Tanya talked about as well. Amazon Health, which is using it for patient engagement and data analytics. Just as an aside, Amazon Health is also utilizing AI as part of their Amazon Prime membership information, as well as their PillPack company that they recently purchased in the last couple of years. It's integrating all of those things together so that they can provide real-time prescription delivery to you via drone if you're a Prime member within a 5-hour time scale. And again, all part of providing additional clinical benefit to you as a patient, and obviously integrating their businesses with the supply chain that they currently do obviously a stellar job in the supply chain and logistics space. And they purchased that PillPack company, which is unit dose pills. So they are a pharmacy supplier essentially at that point. And this is a real competition, very real competition for Walgreens, CVS, et cetera. In fact, a few years ago, Amazon asked those companies to provide those pharmacy services before they had PillPack up and running, and Walgreens and CVS declined because they knew this would be a direct competition to their businesses. Yes, there's a question.
No questions?
Yes, yeah, I do.
Oh, I'm sorry.
Yep, no problem, not a problem. We're just sitting here listening and enjoying what we're hearing, and we appreciate it. Did have a question, obviously. We're hearing so much now about our large organizations like Google or Amazon or Microsoft diving into patient data and information. We know that in our state, Epic was developed or has been used for healthcare analytics for a long time. Can you just comment a little bit about what you're seeing on the security of patient data within those broader organizations, Amazon, Microsoft, Google?
Yeah. So I'm probably going to just scratch the surface because it is a challenge. Some of these companies have been in the healthcare space for a while, so obviously they have spent some time thinking about the security of that data. But as we see new and emerging companies, and I know Tanya and I both, work with startups, they are every single day. I'm not as confident in their abilities to secure patient data. And there's a lot of investment. There's a lot of venture capital investment in this space. And so I think there is real reason to think about how we do protect patient data in these arenas. Certainly, it is a challenge for any organization, any large organization, to avoid being hacked. And we all have received a letter from somebody, including Change Healthcare. I think I'm part of I live in the state of South Carolina, and I'm part of a breach for the Department of Revenue for South Carolina, for Change Healthcare, and a variety of others. I feel like I get one of those letters, every 6 weeks or 8 weeks or so. So I think that is a challenge. And again, I'm just scratching the surface there, and I would say there's more to say there. And another question?
Yeah. Oh, hi, Michelle. This is Senator Martine LaRoque-Gulick from Burlington. I think a lot of us feel as though for-profit healthcare system is not working and frankly is broken at this point, and we'd love to see a more universal healthcare approach. So in that vein, I'm wondering, do you have information on what other countries who do have a universal healthcare approach, if they are heavily relying on AI or not?
It's a great question. I happened to work with the National Health Service in the UK for 2 years, several years back. And I do know that they are utilizing artificial intelligence. I think that is just part of healthcare now. Unfortunately, that train has left the station across the country. I do understand the universal healthcare question, and I think that what we are seeing is the base challenge that invited us to this discussion exists at the federal level as well. I'll talk a little bit about that, but the OMB has identified, for example, any bills that came through the OMB for telehealth have always scored high because of their concern for overutilization. So if we have concerns about solvency, if we have concerns about overutilization of care, or is that access to care? That's the balance. Have we just improved access to care versus defining that as overutilization? Where does that drive us to? It's a great academic question where you might use AI to determine that. Where does that drive us to? Does it drive us to a universal healthcare payer system, or does it drive us somewhere else? It's a great question. In those universal healthcare countries in the United Kingdom, as well as Canada, they are utilizing AI, but again, they are not payer based. So our system of healthcare is all about reducing cost and generating revenue. Their healthcare systems are all about reducing cost. They don't have the generating revenue element. And so they're looking at reducing the cost of the patient, lifetime cost for that patient, and how do they drive overall cost in caring for patients over their lifetime. And Tanya, do you have something to add?
I just wanted to add, and I can get it to you, the dermatology study was done out of Hungary, and because they have national health insurance, and the results that they got, where they were able to find skin cancer better, faster, more effectively. I'll just shoot that to Daisy. But I felt like they were able to do that study because it was national health insurance.
Yeah, and that's a great point, and we see that in the VA. They actually have, because they're a federalized system, they almost mimic a universal healthcare system, and they're able to do studies much more quickly because they have a large database. We also see that happening in Epic, because Epic is the largest footprint of EHR across the country, and they have an internal HIE, internal health information exchange. They essentially can do large population health data set analysis for the purposes of reducing cost of care. Because obviously it's a morbid statement, but if you're actually catching and improving health and overall public health, then people are living longer and they actually cost more over time, right? So there's a push and pull.
Thank you.
You're welcome. And we just talked about Epic. So they are using predictive healthcare analytics, among other things, in their systems. So this is a couple of case studies just looking at, oh, excuse me. I'm sorry. I just had a little challenge with my technology there. There we go. Things are looking weird on my side, but I'll continue. So for Microsoft, for example, they are utilizing ambient voice AI in healthcare and utilizing Nuance's Dragon technology. So if you have some experience with healthcare, then you'll recognize Dragon is a very popular technology which clinicians wear all the time on them. and they use it to communicate with each other and to determine where they are located inside of an institution. This has lots of benefits for them. Obviously, knowing where nurses are, knowing what's happening, they can communicate and say, hey, I need help with this patient. I need someone to come in and help me turn them, or I need someone to help me with wound care or whatever. So this is a very popular technology, and it's using their Copilot technology in order to reduce the editing time and streamline that workflow for physicians. So very similar to the technology that Tanya showed as well. This is piloting at Vanderbilt University and expanding across and it's over 600 healthcare facilities and providers now. And this information was in 2024. So you can imagine this is proliferating. This was in August of 2024. Again, there's the link for you to be able to see that. So it will continue to refine that technology in real time based on clinician feedback, aiming to improve the efficiencies and reduce the administrative burden in those healthcare settings. This is a small company that has a lot of venture capital venture capital funding behind it. It's an AI workflow automation platform, and it is using what's called straight-through processing. And they're using this to send claims straight through. So we talked a lot about how there's a middleman usually in claims processing, where typically the health system or clinic will produce a bill with their coding and everything is complete. And then it goes to a third party who will make sure that everything is correct and will tell them, hey, there's a problem here and you need to fix this, etc. So that extends those timeframes. This is called straight-through processing, and they are improving the percentage of data processed without any manual intervention. So they are utilizing generative AI. They're utilizing obviously in their testing, they're seeing that humans were unable to differentiate in AI conversations with humans being unable to differentiate in AI performing those tasks. So this is, again, an ethical question of whether or not the patient should be aware that AI is actually performing tasks end to end. But in this case, it's because the natural language processing and the learning language processing and machine learning is actually learning and instantly assimilating that information, that new information. It eliminates the needs for complex training and processes over millions of documents monthly. They're saying that they have over a 90% straight through processing rate, which is leading to significant productivity and costs. So the example that Tanya talked about earlier, where the cost of the AI is absolutely worth it to these clinics. This is a good reason why.
Can I ask a question? We're seeing a lot of vertical integration in our healthcare system. Insurance companies, pharmacy benefit managers, pharmacies, third-party administrators, claims processors, clearinghouses. Is AI is there investments being made to sort of incorporate some of these AI companies into larger? I mean, I know you have a slide on Epic coming up, which we're very interested in because most of our hospitals in the state use Epic.
Yep.
And I'm wondering if we're seeing vertical integration in this area as well.
And let me make sure I understand your question. So are the AI technologies being utilized to connect pharmacy benefit managers, to connect hospitals, and to connect insurance companies or insurance company arms within the healthcare cycle? Is that what?
Yeah, I mean, you're giving the case study of this AI automation platform, which is removing the claims processing, the third party clearinghouse. So if you think of Change Healthcare is a subsidiary essentially of United Healthcare.
Yep.
And I'm wondering, if they're losing business, it seems to be the experience in our healthcare system that they're not going to let that happen, and they're going to start acquiring all these other things. So I'm wondering if we're seeing that.
That's a great question. I haven't seen that, but I certainly think that's possible. Those large companies would easily want to snap up a company like this, which is why you see it raising over $42 million, because most of these companies that are venture capital backed are built to sell. And so they're looking for buyers like that, where they will not lose their footprint of business. So Change Healthcare, for example, let's say they were a buyer for this company. And I don't know much about this company other than what, so I'll leave it there, what you see here. But if Change Healthcare were to purchase this company, for example, that would ensure that they continue to keep their market share versus allowing another company to purchase it. So yeah.
Thank you.
Epic and Microsoft have a collaboration and partnered to embed their GPT-4 AI into all of their EHRs and into all of their EHR technologies. And it is obviously assisting with clinicians to generate the draft responses for patient communications. It uses their Slicer Dicer tool, which helps them analyze patient data more efficiently as well. Slicer Dicer tool is kind of like a reporting tool, but it spits information back out to the physician so that they can look at those communications and look at data in aggregate and in summary and see where there may be insights that they might want to take advantage of for individual patients and patient communication. They have introduced over 100 new AI capabilities in the last couple of years, including tools that help doctors simplify those instructions for patients. These can be very helpful when you're looking at language levels for patient education as well, and obviously automating their prior authorization process. We see this a lot with AI, utilizing this for prior authorization. It is a very time-consuming and resource-intensive, activity to do prior authorizations. Person on the phone calling to the insurance company. This is also true for the insurance company. They have to have someone on the other end telling them whether or not the person has prior authorization. So automating that on both ends is very helpful, and in assisting in the draft insurance denial appeals. So anytime that a patient has a denial, they're able to utilize this technology, and that will assist them in responding to those denials to potentially get the patient approval for the services that are being recommended by their physician. It's also being integrated into Epic MyChart, which is the portal that you would access for your communications with your provider for patient messages, leveraging that relevant medical history and lab results, and able to, again, pull and aggregate that information together quickly for the physician and clinician on the other end, and also for the patient. So they can easily see that information in summary, and it's very clear and easy for them to utilize. AI and medical billing and imaging, those future AI features, which they talked about in May of 2023 with this news post. This is already in play. Will analyze those medical images, calculate wound, and potentially look at how they do the direct submission through Epic software. So when we talked about the NanoNets, and that was doing straight through processing, so again, no third party, this is exactly what Epic is doing as well. There will be no third party intermediary. It will go straight through from Epic to the insurance company, again, reducing those AR days that we talked about, improving clean claim processing, and improving payment.
I just wanted to, I see that you have several more slides and we are running out of time and I wanted to make sure that I left room for questions. I was wondering if maybe we could just touch very briefly on the slides you have left.
Absolutely. Let me try to skim through. The BetterHelp, this is actually something that is a concern that has happened because BetterHelp has been utilizing AI to return messages to patients. So the patients thought they were getting actual clinical and human intervention, but they were not actually talking to a human. So should the patient be aware that this is AI? My personal opinion is yes, and patients should be protected from this type of, in some ways, exploitation. So that's something to consider. The Office of the National Coordinator is actually responsible for the guidance related to technology. So it's a good resource for you to continue to utilize. They have principles related to AI. Their FAVES principles that it should be fair, appropriate, valid, effective, and safe, transparent, mitigate risk, as well as have governance over the AI to track multiple applications, establish policies around this, and AI and certified health IT programs should have predictive decision support interventions, and they have to follow the ONC regulations for transparency, data traceability, and user control. So any technology that is currently coming through with AI technologies and wants to be a certified OINC certified health IT technology has to adhere to these principles. So it's a good hook if you want to utilize that in any of your potential legislation in the future. We talked a little bit about and thought this might be interesting for you to be aware that there are payable CPT codes. Tanya touched on that with diabetic retinopathy. Today, that is happening through AI analysis, and there is a CPT code for point-of-care diabetic eye screenings using AI-based image interpretation. This is typically used in primary care settings to improve the diabetic retinopathy screening, specifically with diabetic patients. This has little to no provider intervention, and private payers and CMS are also offering a variety of incentives to encourage the use of this technology in their treatment of their patients. There are a couple of cases that I thought you might be interested in that are happening with AI, specifically around transparency, privacy, and other types of issues that are happening. So the United Healthcare used predictive analytics to, and is facing a class action lawsuit. They used it to deny claims. Specifically in this case, it's claiming that they did it for extended care to elderly patients, using AI to prematurely discontinue coverage for post-acute care in skilled nursing facilities. When at the end of the day, those court documents indicated that about 90% of those denials were reversed upon appeal, suggesting that the algorithm was in fact incorrect and made mistakes in that case. Humana is also being sued for utilizing AI, the same type of AI tool, again, to predict and limit post-hospital care. And in this lawsuit, they're saying that the employees at Humana were pressured to adhere to the AI-generated predictions rather than use medical necessity, leading to an increase in denial of claims. Again, these are cases that are cycling through, so haven't been defined yet. This is just a case that was brought. So we don't know what the decisions are at this point. Those lawsuits highlight concerns that AI-driven decisions may prioritize cost reduction over patient care and potentially force seniors to pay out of pocket for medically necessary services and discontinue care prematurely. So I left those links for those articles as well. Some of the bills that are cycling through, you should know that this is an issue that every single state is dealing with, as well as the federal government. Interestingly, another area to pay attention to is the American Heart Association. They do a great job of tracking policy. American Telemedicine does as well as the Center for Telehealth Policy and eLaw. There's a work group for AI in all three organizations. But California is also struggling, requiring healthcare providers to disclose when AI is being used with patient communications. And they're also saying that this ensures decisions about medical necessity cannot be solely made without input from a licensed provider. Colorado is regulating high-risk AI systems, requiring transparency and safeguards in those algorithms. Illinois, the same. They want to have an annual impact assessment for automated decision-making tools. Rhode Island also requiring insurance coverage for AI-based breast tissue diagnostic imaging if it's reviewed by a qualified physician or a qualified health professional, or QHP. Utah, this is the case that Tanya brought up, AI disclosure requirements and regulatory oversight. Washington, same, creating a task force to assess AI applications in healthcare, and your recent law in Vermont to assess AI risks and develop ethical guidelines for safe implementation. Some things that you may want to consider is patient trust development is impacted with AI usage. There's a potential for major insurance industry changes, which may be difficult for the public to navigate or understand. And how will they address that? And how will the public be educated where insurance processing is already difficult for patients to understand? And there could be major shifts in the way that the insurance industry operates. The OMB models, which is the Office of Budget Management and Budget, the federal government defined overutilization of care for virtual care services, which I mentioned before, always scored them high, causing them to abandon the widespread payment model and only include carve-outs. So this is what we're seeing is some carve-outs happening within individual states and payers as well, and saying we're going to pay for these elements, but these that are carved out, but not all AI elements. Other states are considering implementing roundtables or AI boards to develop ethical use practices for payers, health systems, and researchers. So the researchers also important. Tanya touched on this in her presentation, where this is helping with clinical trials, but we want to make sure that those clinical trials are meeting the same standard peer reviews that we're seeing today across, and again, continue to improve patient trust in these technologies, and utilizing patient advocates to teach how AI is being used to educate the public. The public doesn't always understand how AI may be utilized across many different spectrums, but particularly in healthcare. I thought there's an interesting quote from Blue Cross Blue Shield's Chief Information and Digital Officer at Wellmark, that innovation doesn't necessarily improve the cost structure, it extends life and improves outcomes. So obviously that has implications for both the patient, the providers, and the payers. I appreciate your time and engagement with this. It's so important, and I'm happy to take additional questions.
Thank you. And I can hear the bells ringing for the Senate, and so I'm assuming we might be losing our Senate colleagues. We already did.
Sorry.
Yeah, okay. I have a couple questions, and so I'm going to start with Topper, and then I see Brian up on the screen, and I know Woody also has a question as well.
First of all, thanks for this. My question is this. We talked about AI being biased. And I'm wondering about, after looking at the Epic piece, if somebody went into the hospital with a problem and there were 3 ways to fix that problem, would Epic, with the AI piece that they have, would they decide that the most expensive solution to the problem was the best way to go? Since the hospitals in Vermont are in trouble and they're trying to make money.
Yeah, I mean, theoretically, yes, but there's a pretty hefty patient and ethical guidelines that, I mean, I know from my own work as a hospital employee for over a decade, that we always had the mantra of it doesn't matter what the payment is, that, you know, you're treating each patient the same. So I can imagine that would have to be a cultural shift in healthcare itself. But theoretically, the technology could do that, yes.
Thank you.
And Brian?
Oh, Brian
Yes,
has a
yeah,
question.
I didn't know I was next, sorry. So I've been listening and hearing a lot about the use of AI for information management and like business practices. And what I'm wondering about is what you might have to say about how it's sort of pushing the limits of AI a bit into, I don't know what to call it, other than maybe neurological rights, where we see technology coming out like Neuralink, for example, which is an Elon Musk company that's developing circuitry that integrates into the brain and can be used to circumvent problems. So people, for example, who are paralyzed may be able to walk again because of this technology. But there's not a lot of people looking at what kind of neurological data they might collect once there's implants, or how companies could use implants to influence our behavior. So I'm curious what you might have to say about the use of AI in that regard in the healthcare sector.
Yeah, I mean, it's a great question. It's why we see things like the Apple Watch, which I'm a believer in, but my young son thinks that it's dystopian, that it reminds me that I need to stand up, or that it reminds me that I need to do my, step goals. I think, the data that can be collected, this is also true in women's health. What aggregated data is happening there, where it's collecting menstrual cycle information. It doesn't even have to get to that point of where you're talking about, where it's, what is it collecting in your actual mind? But it's data that we are actually providing to trusted healthcare professionals, which is where I think improving patient trust in these models and understanding where those guardrails should be. This is the challenge that you have, and trying to address something where the train is out the station and is already 10 miles down the road. So I think, yes, it's an important question. What can be utilized? What should and can be done with that information?
Woody,
I'm done.
Brian, I'm sorry, were you?
I'm okay with that. I mean, I want to make space for others to ask questions. I could talk about this topic with our guests for hours if I had the time. So I'm just gonna digest things, and thank you.
I know that about you, Brian, which I think is why I moved on to Woody quickly.
We left our contact information on our slides, Brian, so feel free to contact us.
So you mentioned in the Office of National Coordinator for Health Information Technology. Is there a federal regulator or overseer of AI currently, like a Department of AI? Probably not.
I'm not aware of a Department of AI. I know that right now we know that President Trump really wants AI to be his, so he is pulling it into his major agenda. So he is, I would not be surprised if that is already, being discussed. Right now, those guidances and regulations come out of the ONC through the technology arms. We'll see what happens with HHS around that, and how President Trump will take that to the next level.
But the ONC doesn't really have any regulation authority, or is able to bring charges against a company that's out of its area, I guess.
Right. I don't know if I would have to find out. I could get back to you and see if there's one of the committees has AI oversight in, say, the House or Senate, and what the Department of Justice has in terms of AI. I know that the OIG, despite right now not having as many people in the Office of Inspector General, they have had quite a few cases that they have been bringing that have included AI. Most of the cases that I've seen have been public driven or civil rights driven.
Thank you.
Thank you. Thank you both so much. A lot of information to digest and think about. Topic we certainly have never delved into before, but I feel like we're going to need to become familiar with it. So thanks for joining us. I think we're going to take a break. We need a break. So can we let's go for a 10-minute break and be back here at 11:15.
Thank you